Afternoon and welcome to the webinar titled Grief and Bereavement. This is the fourth webinar in the MJHS Interprofessional Webinar Series. I'm Dr. Alessandra Strada and I'm the Director of Integrative Medicine and Bereavement Services at the Institute for Innovation in Palliative Care at MJHS. And I'm very pleased to be with you today and have the opportunity to talk about this very important topic, which is so relevant for all clinicians working in the palliative care and hospice setting. I have nothing to disclose, and during this webinar we will first discuss some of the current conceptualizations and theoretical models of grief and bereavement. We will review some of the most common grief reactions in the palliative care and hospice setting with a focus on anticipatory grief and complicated grief. We will touch on elements of assessment and differential diagnosis, and we'll also review some of the evidence-based applications and interventions that can be utilized in the clinical setting to improve the quality of life of patients and families. So we said that this topic is very important for all of us, and why is that? Well, if you think about it, grief is really, for many patients and families, the common denominator across the continuum of illness, from the moment of diagnosis, during treatment, during transitions of care, in end-of-life care, and in bereavement. So in order to really understand the patient and family's experience, we need to understand how they grieve, how they understand, conceptualize, experience, and express grief. Also, if you think about the 8 domains of palliative care, you may recall that the third domain, which is the psychological and psychiatric domain of care, really psychological and psychiatric really includes the grief and bereavement care as one of the subdomains and describes several guidelines that can be used for best practices. We also know that grief reactions can be very intense, and the manifestations can overlap with other disorders or other conditions such as depression. So it's especially important that clinicians, palliative care clinicians and hospice clinicians are able to differentiate between what is a normal grief reaction that needs to be supported and what is a complication of bereavement or a complicated grief reaction that needs to be addressed in a professional manner. And this will allow us to describe and to formulate treatment plans that are really integrative and can benefit patients and families. So I would just like to take a couple of moments to review definitions and key concepts, and I realize that this is a review for many of you, but I think it's important to spend just 2 minutes because in the grief and bereavement literature, often terms are used interchangeably, and this can create confusion for clinicians. So just to define the terminology, it all starts with the experience of loss. And loss is really the core experience that we're talking about today. Loss is the state of being deprived of something or someone important. Patients and families, as you know, experience several losses from the moment of diagnosis throughout the continuum of illness, as we said. Some of the losses are physical losses. Think about the loss of a body part during surgery, after surgery, cancer surgery, for example, or think about the disfigurement that certain surgeries, cancer-related surgeries, can cause, such in patients with head and neck cancer, for example. Some losses are symbolic. Think about loss of identity, loss of role in the family, loss of status. So it's very important that in order to understand the patient and the family, we understand what kind of losses they have experienced and how they have made meanings of these losses. When we talk about patients and families in team meetings, we often will use terms such as the patient is coping well, right, or the family is adjusting. And this is, well, this is true, of course, and this is certainly accurate. But the fact that the family and the patients are adjusting and coping well does not mean that underlying that adjustment there is an grieving process, an ongoing grieving process that the patient and the family is really trying to manage. So we need to understand that there's this dialectical approach, grieving and adjusting and integrating. Grief is the term that we use to indicate the psychological, physical, spiritual, and cognitive manifestations, reactions really to a meaningful loss. Bereavement is also the term that we use to indicate the state of having lost someone close to death. Mourning indicates the psychological process of integrating the pain of loss. And so this is an intrapsychic, intrapersonal process of adjusting to the reality of the loss, to adjust to a world that is very different from the way it was before, and define also a new identity in light of the loss. Mourning is also used to indicate the outward manifestation of loss. And so we're talking about funerary practices and the way the community grieves together and make meaning of the event. Anticipatory grief is also called preparatory grief in the literature, and it refers to the grief reaction that is really that occurs before the death of the patient and results from the expectation of that death. In the literature, often there is an emphasis on caregivers and their own anticipatory grief, but we always need to remember that patients go through a very similar process in terms of adjusting to the worsening of illness. And of course, there are variables that affect their grieving process, and we'll talk more about that in a minute. Complicated grief, also called prolonged grief disorder, indicates a pathological grief reaction. This is a pathology and always needs to be addressed professionally. Complicated grief indicates a situation where the mourning process, remember the process of integrating the pain of loss, becomes symbolically stuck. So the griever becomes unable to continue to integrate the loss, and so they're kind of stuck in that and experiencing severe distress from the loss. I just wanted to point out that the term complicated grief and prolonged grief disorders were developed by two separate research groups. However, the criteria are very similar and they indicate a pathological grief reaction. That's why in the literature they're often used interchangeably. Disenfranchised grief is something that we all should be very familiar with, all of us clinicians, because it really describes a grief reaction that is not sanctioned by society. So where there isn't that societal permission or support to grieve. Let me give you an example in the broader context. Great miscarriages generally result and really don't necessarily receive the attention that they should, or loss of a pet, the death of a pet. So society tends not to really provide a lot of support for grievers in this situation. Certainly things are changing, but this is generally what it's been until very recently. Think about the palliative care or hospice setting. Let me just give you an example of disenfranchised grief. We may have a family member who's been estranged from the patient for many years. And now that the patient is approaching death, this estranged family member shows up and would like to be part of the circle of support, but the patient may not be willing to engage. The family member may want to look for forgiveness and reconciliation. And as we know, these concepts are very complex at end of life. Sometimes reconciliation is possible. Sometimes it's not only possible, but it's not even desirable because of complex family dynamics that have been going on for a long time and cannot be addressed in a timely manner. So the griever who's been left out of the circle of support of the patient may feel that their grief is disenfranchised. They don't have enough support, and they may not be able to reach out for further help. And I just wanted to mention chronic sorrow, which is a term, a grief reaction that actually caregivers who care for someone with Alzheimer's type disease or other degenerative diseases can experience, because every day brings an ongoing series of progressive losses. And so the sorrow, the grief becomes really chronic and kind of a way of being. So now that we've reviewed some of the key terms, I'd like to switch gears and talk a little bit about current conceptualizations of grief and bereavement. The way we think about grief and bereavement today is quite different from the way it was decades ago. And now we have the advantage of several research studies and large population studies that have really helped us understand the deeper nature of grief. But the early models of grief really focused on the importance of grieving the right way and then moving on, in a nutshell. It was believed, starting with Freud, and don't get alarmed, I'm not going to talk about Freud, but he was one of the first people who really indicated the importance of the grieving process. He differentiated between mourning, a normal grief reaction, and melancholia, which is what nowadays we would call clinical depression. But the idea was that there was a right way to grieve And that way was to express a significant amount of distress and sorrow and sadness for a long time. And then at the end of that process, of the very intense process of suffering, the griever will be able to withdraw energy from the image of the deceased and invest it. What we know now, also thanks to the studies that I've mentioned that have really given us a much broader understanding, fortunately what we know now is that grief is a very unique process. It's a common experience, but it's highly unique for each individual. There really isn't the right way to grieve. There isn't a right way or a wrong way to grieve. There may be pathological grief reaction, but that's a different story. So the challenge for all of us clinicians is really to understand for each patient and family member what is their grieving style. Do they experience grief more as an emotion? Do they become sometimes overwhelmed with the pain of grief, and do they benefit from crying and from asking a lot of support and debriefing and talking about the loss, versus other patients or caregivers who may experience grief more as a thought, and in that way they move into action. They're a lot more pragmatic in the way of grieving, or kinesthetic. So they will ask you things like, what can I do? I need to do something. And through the doing, they actually process their grief. We also know that it's not necessary to disconnect or disinvest energy from the image of the deceased. In fact, recent models emphasize the importance of legacy and maintaining a symbolic relationship with the deceased, because this can be very supportive for grievers. Also, recent studies have highlighted the importance of resilience. And so what we know now is that some grievers, even though the loss can be very meaningful and very distressing, they don't necessarily experience or express strong affect. Rather, what they do is they're able to return to a level of functioning that is acceptable to them relatively quickly. So they may be able to go back to work and engage in daily activities. And that reaction should not be pathologized. So strong affect is okay, not strong affect or ability to go back to a level of functioning relatively quickly is also kind of understandable. And what we know about grief is really that it's a dual process. It fluctuates. So mood and affect really fluctuate for patients. There are ups and downs, moments of profound distress, and moments where the griever is able to engage, maybe for a few moments or a few hours, and then return to a more loss-oriented process. So now we're reviewing normal grief. We're talking about normal grief, and I just wanted to briefly summarize what are some of the normal manifestations of grief, because in reality we say grief is normal, but it does not feel normal to the griever who's experiencing it. There may be profound physical, emotional, spiritual manifestations. So think about your patients or caregivers who may be grieving. And think about shortness of breath, which is a common reaction, physical manifestation for some grievers. Think about a patient with advanced lung cancer who already has shortness of breath, and now we have this superimposed grieving process which may exacerbate the physical symptoms. Body aches, dizziness, nausea, panic attacks, severe anxiety, physical numbness. In the psychological and cognitive domain, we can have a range of emotions, from numbness to relief to guilt, and all of these emotions can be experienced actually almost at the same time, creating a tremendous amount of turmoil for the individual. Also, there can be disorganized thinking, and it's important that we remember this so that we can educate caregivers when they tell us, you know, my memory is going, I don't understand what's happening, I'm losing control, I read a page of a book, and then I can't remember, I don't know where I put things. So we need to normalize the fact that attention and focus and concentration are also affected by grief. And there also may be fleeting, and I really want to underscore fleeting or transient auditory hallucinations or visual hallucinations and perceptual disturbances. And this can happen. Let me give you a quick example. If a caregiver has witnessed a loved one on the hospice, for example, in palliative care, in the palliative care setting, experiencing severe distress and poorly managed pain, or poorly managed delirium agitation at the end of life, or poorly managed dyspnea, they may actually keep hearing the loved one calling out in pain, and this could be part of really of their bereavement process. In terms of the spiritual manifestations of grief, well, we know that a spiritual and religious affiliation can be very protective for many individuals. However, during the grieving process, some individuals may not feel that supported, and they may develop conflicts in faith belief. They may develop a loss of meaning and purpose, existential spiritual distress, and all these issues have to be addressed by a spiritual care professional, and we have to be alert and really be aware that this can happen. So let's switch gears now and refocus on anticipatory grief. We're talking about anticipatory grief, also called preparatory, in patients. Kubler-Ross described it really eloquently as the grief that terminally ill patient has to undergo to prepare himself, and herself of course, for his final separation from this world. So anticipatory grief, preparatory grief, really indicates the process of adjusting to imminent death or worsening of illness. And of course, we need to understand that the awareness of anticipatory grief and the processing of anticipatory grief is modulated by many variables: cultural, personal, family dynamics. Awareness of prognosis is really a significant one. So it's not just a direct process, it is modulated and affected by all of these variables. Like I said, it is not pathology, but it can become unmanageable. It is different from depression, and we will review that in a moment. However, let's remember that in a clinical setting, things are not always as easily either this or that. So grief and depression can be comorbid. It's important to remember that. And just to summarize, the core difference between anticipatory grief and depression, or the core experience of anticipatory grief, is that really it is a fluctuating process where patients may feel able to engage one moment and completely distressed the next. Anticipatory grief in caregivers. I'm talking now about family caregivers and all of those people who rally around the patient and are very involved in the patient care. Anticipatory grief is normal, but can become unmanageable, and thus it requires ongoing monitoring. Certainly there are cultural variables that we need to be aware of, and we need to keep that in mind, because in certain cultures it is very important to grieve, to express a lot of distress, very strong affect, and to continue that after bereavement. However, if the caregiver, for example, becomes unable to take medication or refuses to take important medication, and we're talking about people with a physical illness or older caregivers, it's really important that we monitor that process, and we may need to intervene and design a treatment plan for them as well, because it may become really dangerous if they're no longer able to take care of themselves or take medication that are really important. So we need to be aware of the cultural expressions of grief. We need to take that into account, normalizing when possible, supporting, but always keeping our assessment hat on to monitor for distress that becomes unmanageable. So let's touch on an assessment component here, and let's discuss briefly the differentiation, the main differences between preparatory or anticipatory grief and clinical depression. Essentially, as I already mentioned, in a preparatory grief, mood fluctuates. And let's just review. Mood is really how the patient describes their feeling versus affect, which is what you observe as a clinician. So they may have very low mood one moment, but then they retain some ability to engage with loved ones and family members. If they're in a facility, they may look forward to a visit of a particular friend or loved one. And then after the visit, they may feel exhausted, or they may start grieving the fact that they will not be able to engage with loved ones for much longer, especially if the prognosis is very limited. So it's an up and down, it's a fluctuating process, and the sense of meaning may fluctuate as well. They may be able to plan for a year from now, even though they have an awareness that their prognosis can be very limited. Now, in clinical depression, mood is low most of the time, affect is generally flat. There's very little, if anything, that can cheer up the patient or the caregiver experiencing it. There is in patients a withdrawal from families and friends, but let me just note that this kind of withdrawal needs to be differentiated from the normal and expected and natural withdrawal that often occurs just during the death and dying process. And really the hallmark of depression can be described as anhedonia, the inability to experience any kind of pleasure. And generally the loss of meaning is across the board and is complete. Now, let's remember, as I mentioned earlier, that patients and caregivers may experience both preparatory grief and depression. And this is when the clinical picture becomes more complex, of course, for us clinicians. Now let's talk about complications of bereavement. Let's talk about complicated grief as a pathological grief reaction that needs to be addressed. Just to review, the individual who's experiencing complicated grief is in the mourning process is frozen or stuck. They become unable to process the pain of grief, and so they continue experiencing these very distressing symptoms with no relief. There's really also an inability to accept the reality of the death. We want to be mindful of cultural differences, of course, but this is a pathological reaction, so we want to normalize whenever possible, but we do not want to trivialize what is a pathological reaction with very distressing feelings of separation distress, with intense longing, yearning, and pining. There may be anger and bitterness and shock and disbelief and behavioral changes. And of course these symptoms, these manifestations can be present in normal grief as well. But in talking clinically now, while in normal grief you have fluctuations, remember the fluctuations, and you have the sense as a clinician that the grieving process is moving forward. In complicated grief you really get the sense that there's no relief, there's no movement. It's like the psyche has become unable to process the loss and the reality of the loss. Several studies, no, we don't have the time to review today, but several studies have really indicated that complicated grief is a syndrome different from clinical depression because it's much more focused on the loss. And caregivers can experience complicated grief, so we need to monitor them for risk factors. But let me just make a note. The focus on complicated grief is generally related to caregivers. So when we do pre-bereavement in hospice, we say, well, let's talk about the risk for complicated grief for caregivers. Let's not forget that patients may come on hospice or may be enrolled in a palliative care program, and they may have experienced a significant loss, let's say a couple of years prior to their admission to hospice, and they may be experiencing complicated grief at the time of admission. So this is not something, a pathological reaction only for caregivers. Patients with advanced illness may also already be coming onto the program experiencing complicated grief. So what are some of the risk factors that we need to keep in mind and we need to monitor for? I'm going to describe some of the risk factors identified in the literature. Certainly relationship and attachment style are important. A high level of ambivalence in the relationship when there's love between the caregiver and the patient, but also a lot of resentment, a lot of ambivalence, a lot of unprocessed feelings and emotions and negative, especially if these are negative, can complicate the bereavement process for the caregiver. Also an extremely dependent attachment style, not just being close, that's a good thing, but dependent in a way that the caregiver cannot possibly imagine the life without the loved one. And again, all of this is normal, right? These feelings are normal, but we're talking about a situation where the caregiver can become completely unable to function at any level. Personal vulnerability should always be taken into account. A prior history of depression or anxiety disorder or psychotic disorder in caregivers, for example, should be considered the risk factors. Circumstances of the death. This is a really important one because we may think that because patients have enrolled on hospice that the death is expected. However, let's not forget that even the most highly functioning caregiver at the time of admission may experience a profound grief reaction that they're trying to manage. That may interfere with their ability to really process what is happening and really process how limited their loved one's prognosis can be. So we need to keep that into account and always remember that patients and caregivers, when they're grieving, they become unable to process information to the same degree of someone who's not grieving, because really grief interferes with the ability to process a lot of complex information, especially if it is distressing. And the psychosocial context of the death is also very important because financial stressors and other psychosocial stressors related to housing can really complicate the bereavement process. So I would like to now switch gears. We've reviewed anticipatory grief. We've reviewed briefly complicated grief. And I wanted to just mention for some of you who may be familiar with the DSM, some of the main changes, two main changes that have occurred in the new edition of the DSM. The DSM is the Diagnostic and Statistical Manual of Mental Disorders. So the new edition, the DSM-5, contains two interesting additions and changes related to grief and bereavement. And I think this can be relevant for all the mental health professionals out there. First of all, you may know that complicated grief was included, was proposed as a separate diagnostic entity for inclusion in the DSM-5. And the DSM-5 task force has rejected this proposal. However, they have developed a new terminology, persistent complex bereavement disorder, as a condition for further study. They have described clinical criteria that, however, should not be used clinically, but only for research purposes. However, I would like to mention that most clinicians in the field believe that complicated grief does exist, that it is different from depression, and will continue using this terminology unless something else comes along. The second change is really even more relevant because it is the elimination of the bereavement exclusion criterion in the diagnosis of major depression. What does that mean? According to the DSM-4, if an individual was acutely bereaved, and expressed a lot of depressive symptoms, they could not be diagnosed with major depression for 2 months, because it was believed that while the individual is bereaved, so this depression is normal and part of bereavement, so we shouldn't over-pathologize a grieving process. So now that bereavement exclusion criteria really has been eliminated, so someone who has just experienced a loss can be diagnosed with major depression. And if there are any questions about that, we can talk more about that later, because it's a relevant change, I think, that has created a lot of controversy in the field. So some of the psychosocial approaches that we need to keep in mind and be aware of. First of all, it all starts with supportive education. And I believe that every palliative care clinician, every hospice clinician should be able to normalize, to describe the grieving process, to educate families and patients when they have questions about what grief is and how we can experience it, and really normalize what is happening. Just explaining sometimes can be extremely helpful. Counseling is an intervention that is a little bit deeper, clarifying beliefs and providing that support for normal grieving. And psychotherapy is really a more in-depth intervention and more structured that is very useful in general to address more pathological grief reactions. And I want to mention complicated grief treatment, which is nowadays probably the most effective evidence-based intervention for complicated grief. It was designed specifically for complicated grief. It's a manualized, structured intervention of 16 sessions, and it contains a combination of prolonged exposure and motivational interviewing elements. And a very recent study this year demonstrated that it's also very effective. It actually was more effective than interpersonal therapy for relieving depressive symptoms in older patients. So it's very important to keep that in mind, but all of us should be able to provide supportive education and normalization of symptoms, still monitoring pathological grief reactions. I would like to make a quick comment just to, as we end our talk, on pharmacological approaches, because this has been an issue that has created also a lot of controversy in the field. Generally, pharmacotherapy, and I'm talking about psychotropic medication, is indicated for pathological grief reactions in depression, in anxiety disorders, and complicated grief. However, the concern that many clinicians have had over the years, the concern that, for example, using antidepressants in normal grief may prevent people from grieving effectively, has not been supported by evidence. So we need to keep that in mind. One of the concerns, however, that is described in the literature is problematic prescribing practices, especially related to benzodiazepines. Psychotropic medication is generally not recommended immediately after bereavement, but there is a tendency, especially in primary care physicians, who may not have the expertise to differentiate between a normal grief reaction and a pathological grief reactions, to especially prescribe benzodiazepines if the individual cannot sleep. And not being able to sleep is normal at the beginning. Of course, if sleep becomes persistently disrupted, the short-term and judicious use of benzodiazepine can be indicated, but not for years. And so some studies have indicated there is a concern. Primary care physicians may start the patient on a benzodiazepines, and then several years later, the patient has difficulty stopping the medication, and with all the concerns related especially to older patients that we are aware of. And just a couple of comments about the use of antidepressants in bereavement-related depression and complicated grief. We don't have very good studies, very small samples. What has been used, and especially tricyclics have been used for bereavement-related depression, and the literature has indicated that these medications are relatively safe, moderately effective. We do know that antidepressants are mostly effective for moderate to severe depression. And in complicated grief, SSRIs have been used to relieve symptoms, and what has been noticed is that depressive symptoms generally improve earlier and sooner rather than grief symptoms. But again, the studies are limited, and hopefully there will be more research in the future that creates a kind of a broader sense of how we should operate and how these medications should be utilized. And in summary, I would like to just highlight that all of us working in palliative care and hospice really need to recognize, identify grief reactions in patients and caregivers, because virtually it's not possible to fully understand and support a patient and a family, I believe, unless we really understand the experience of grief, which is so prominent in their life at this time. All of us should be able to provide basic supportive psychosocial education, reaching out for consults and other providers when there is a need. We want to normalize whenever possible, but always keep our assessment hat on, monitoring for the development of pathological grief reactions. And our treatment plans should be integrated, should be evidence-based, and really be designed and individually tailored to improve the quality of life of patients and families. So I would like to thank you very much for your attention. And at this point, I would like to open it up for questions. And we have a couple of questions. I'm going to give you also a couple of moments to gather your thoughts. And so the first question, what would you recommend if members of the same family grieve differently and this creates conflict? Well, this is a very good question, because we certainly see that. The fact that patients and families may be part of the same family doesn't mean that they experience and express grief in the same way. What I mentioned earlier, for example, there may be a patient who's very private and may not express a lot of affect. They may be distraught or very private about their grief. However, there may be a spouse or children who are very expressive in their grief and would like to be able to join with the patient and bond and cry, and sometimes the patient may push back. And of course, this situation can be reversed because there may be patients who really want to talk about what's happening and they want to grieve with the family, and the family is pushing back because they feel overwhelmed by all this affect. So I think it's a great question because it reflects the reality of the clinical setting, and I think one of the things we can do is really utilize family meetings, and I would say family therapy, family counseling at this point, to really first understand what the issue is, and perhaps there could be a separate meeting with the patient and a separate meeting with the family caregivers at the beginning, kind of understanding how do they grieve and what are the conflicts that are being brought to the forefront. And then having a family meeting, a family therapy meeting, where first of all, different grieving styles can be described and discussed, and I think it's very important that we do that, facilitating connection. Describing the differences in grieving styles is normal, but really refocusing both the patient and the caregiver on what can be connecting them in the expression of love and mutual support. And I also would like to mention that this is the time where we can, in addition to psychotherapy, so psychological interventions, we can use integrative medicine approaches such as music therapy, for example, which is incredibly effective in facilitating connection, really bypassing the verbal modality and bringing patients and families together and reconnecting in an expression of love and mutual support. Okay, we have another question. What concise tools do you use for bereavement risk, and does bereavement ever end? Well, I'm going to, thank you for that question. It's a great question. I'm going to answer the second part first. Does bereavement ever end? I don't think it does. I think when we lose someone close, we are forever changed by that loss. This is what I personally believe. We learn to live in a world that is different. We learn to live in a world without the loved one. And we adjust. We develop other parts of our personality. We adjust to that world. We learn to live with a legacy. Hopefully we're able to integrate that legacy. What may end is the profound distress that doesn't leave you. So there may be some relief, and progressively the moments of profound distress may become more limited. But I also want to remind everyone of a term developed by Teresa Rando, one of the most well-known and most wonderful, actually, clinicians and practitioners in the field. And she developed the term of upsurges of grief. Sudden upsurges of grief, and so what that means is that even many years later, after a loss, once you thought that you've processed it and you're relatively adjusted, a smell, a sound, a situation, the expression on someone's face may trigger a profound grief reaction, and this kind of grief reaction should be normalized because it is part of everyone's experience. And it's almost like a wave, you know, a really strong wave in the ocean, and then it subsides. But just to remind us that the psyche is always really very working with and in relationship with the loss and making meaning. Making meaning of a loss, I think it's a lifetime process. This is why for all of us it's so important to be really acutely aware and very sensitive to the expression of grief reactions in patients and families. And in terms of concise tools for bereavement risk, I think if there are some tools that can be utilized. For example, the inventory of complicated grief can be utilized in the clinical setting. It's relatively short, and you can see how, and we can talk more about this. It's recognized and validated tools. I think the experienced professional, however, can go down a list of risk factors and really look for some of the risk factors that I've highlighted: relationship, prior history, how the caregiver is actually able to imagine their lives without the loved one. I think this is important. Identify psychosocial, so really a thorough psychosocial assessment and spiritual assessment should give us, in the clinical interview, in the context of the clinical interview, should give us enough information to really discuss in teams and decide what kind of individualized treatment plans should be implemented. And I think we have another question. Let me, okay. Euphoria, this is a very interesting question. Euphoria was listed as a symptom of grief. Can you expand on that? Definitely. Some people may react to acute grief to the loss with what we may describe as inappropriate affect, but it's not inappropriate, it's part of the grief reaction. They may become very, very verbal. They may feel elated. I have actually seen this in patients who had the sense that something was wrong with them for a long time and went from doctor to doctor looking for a diagnosis, looking for validation. And then the moment they may actually receive a diagnosis of serious illness, their affect and their reaction may be completely different from what you would expect. And I've been sitting sometimes in the consultation room with the physician and with the oncologist who's actually delivering the bad news to the patient and is really, going through all the processes of being supportive and giving a small message at a time and check for understanding. And the patient, turns to the spouse and says, I told you that I told you that I had cancer, and, I'm so happy that I'm right. And really, I've heard these verbalizations. And they may be elated because finally they felt validated. So it could be a euphoric, a temporary euphoric reaction that really hides this kind of underlying process of grief, which in most cases will come to the forefront later on. So these are fleeting. I'm not talking about a manic state, even though temporarily it may look like that. Because again, grief reactions are unpredictable, and people need to know that this really it's unpredictable how people will respond. Even though they may not have a strong reaction in your office, when you deliver the bad news, they may appear very composed and, okay, we understand, and we go home. We need to find out what happened when they go home, because that's really when they feel safe, that they may be able to express grief in a more authentic manner. Let me look at other questions. Okay. Are there any cultural or spiritual differences in how persons grieve? Definitely. Definitely, and this would be a whole separate talk, and I hope that we will be able to do this in the future. It all depends on how people make sense of the loss. When I provide trainings in person, I always ask practitioners or clinicians, are you aware of the way you grieve? Are you aware of your own grieving style? And sometimes people say yes, sometimes people they say, well, I never thought about it. And I think this is really important because the way we grieve, I think, is profoundly affected by our community, by our family, by our circle of support. And sometimes I ask people, think about the first meaningful loss you've experienced in your life. And I ask them to think about what kind of message did you receive from your community, from your culture, from your spiritual community about what was the right or wrong way to grieve, or how were you supported? What were the messages that you received? Is it okay, for example, for children to be present? Is it okay to express strong affect? Is it, if you exhibit a lot of distress, does it kind of indicate that you are not as religious as you should be, or that you're not as in touch with your source of meaning and purpose that you should be? Is there judgment around how you express grief? And what is the meaning? What do people believe about what death is? I mean, this unfolds a whole different conceptualization and discourse around the meaning of death and what happens, if anything, after death. So that's part of the meaning-making process. And I think it's important that we are aware of the messages that we've received, because sometimes the messages we've received are not necessarily a perfect match with who we are as people and in terms of our own personality. So sometimes I'll ask people, well, do you feel supported by the message or the grieving style that you somehow developed as a result of your family history and your cultural and spiritual religious affiliation? And sometimes you will say, well, no, I really would feel that a different reaction would be more authentic for me. And so in that case, some of the work, the personal work, is really to see what we can shift to find a way of grieving that is more supportive of who we are. Because if we really understand and honor grief in ourselves as clinicians, I do believe that we will be more attuned to the experience of grief in patients and family members. So unfortunately, this is all the time that we have today, and it's been such a pleasure for me to be with you today. Thank you for your participation, and thank you for your very insightful questions. I hope that we can, maybe this is the beginning of a dialogue. And I would like to remind you, however, that the next webinar will take place on November 25th, 2014 at 12:30, and the title is Prognostication 1, Improving Accuracy to Support Care and Hospice Access, and it will be presented by Dr. Pauline Lesage. I also would like to remind you to please fill out your webinar evaluation form, because that will be very helpful for us in future plannings. And again, it's been a pleasure. Thank you so much for your participation, and I'll see you next time. Thank you.